Okay, so I'm going to pick up where I left off in class on Thursday. We didn't really get to spend a lot of time. We kind of raced through croup and we hit asthma. There's not a lot of new stuff I'm going to teach you about asthma because you've taken care of adults with it. You learned about it from last semester. I would stress that you review what you learned last semester. And I'll just highlight on things that are a little different in the pediatric patient. First off, they're not quick to label a child as having asthma. There's something else called reactive airway disease. And they will commonly give them that diagnosis for a while until they determine if this is a short-term or is it going to be a long-term problem. And then they'll move on with the diagnosis of asthma. So, definition is it reoccurs. They get airway obstruction due to a bronchial overreaction to something that's inflaming it. So there's limited airflow or obstruction. It can reverse spontaneously, usually if the irritant is removed, or sometimes it does require treatment to open those airways. So here's a demonstration. On the left side of your screen, we have the healthy, wide open airways. Okay. Then on the left side, we have an airway that is having a hyperreactive response. So in addition to having inflammation and excess mucus secretions, we have the constriction of the airways as well. So you'll see smooth muscle constriction, and that makes it even smaller and tighter. Kind of like we're pinching on a straw that you were blowing through easily before. It can be very frustrating if you're blowing on a straw, and you never know when somebody's going to pinch it. And you don't know how long they're going to pinch it for. And you don't know if you should go see someone to get help unpinching it, or if it's just going to unpinch itself. So that's kind of a quick, very brief summary of what an asthma exacerbation would be. Is that constriction and then excess secretions of mucus from the inflammatory result. Now, because the airways are constricting, what air that was in there is now trapped. So you'll see the picture of the hyperinflated alveoli as opposed to these. You can't get it out. It easily came in, but now it's trapped in there, so you'll have hyperinflation. You have all this mucus secretion. It can become very thick and tenacious, and it can cause a plug, especially when you have constriction. Where's that mucus going to go? So asthma in children is classified. Typically they don't, like I said, they don't like to give them the diagnosis of asthma right off the bat. So about age 5 years is when they're going to start having that diagnosis. So step 1 is a mild intermittent asthma. You never know when it's going to happen, and it doesn't happen very often. Step 2 is a mild persistent. It doesn't clear up easily. It's not easy to get rid of. Step 3 or 4 is a moderate, meaning that it's a higher level of constriction, a higher amount of mucus production than steps 1 or 2. And again, it's persistent, meaning it's difficult to reduce, to get rid of. 5 or 6 is considered severe, and major constriction of the airways, probably having multiple mucus plugs, and a supposed to use to break the asthma exacerbation, which is where you get the airway to open back up. So, how do they diagnose and manage asthma? Well, the first thing they're going to do is pulmonary function test, PFT. That's where they have them blow, and they have them inhale, and they measure, and they see how long they can do it, and how many times they can get a full force exhale and inhale. And that determines pulmonary function. They're also going to do skin testing for allergens, and if you've never had this done or seen it done, they're just like little tiny wires that they scratch, and they have a pattern on the skin, and they scratch for each allergen, and they're looking for a skin reaction, a local reaction to the allergen scratch. So the goal when treating asthma is to maintain a normal lifestyle, and you do this by preventing exacerbations or asthma attacks. You want to reduce the occurrence of them. So what's the drug therapy? And I know we talked about this because we covered it in lab. So there's long-term control medications, there's quick relief medications, meter dose inhalers, steroids, and then cromolyn sodium. Be familiar with these. You're going to want to know them for your test. But what you really want to know and understand is the type of education you give the patient about these. Assume that they don't have insurance. Assume that they're going to try to save money, and some of them they're going to say they don't need. And some of them they're going to use way more than they should. Basically, and I saw this a lot, your long-term control medications are more expensive. And your meter dose inhaler and your albuterol generic forms are a lot less expensive. So what you'll see is they won't fill the long-term medication prescription. They'll get the meter dose inhaler, and they'll use that all the time instead of just for rescue inhales. So you want to make sure you educate plenty on that. What you see there is that's a meter dose inhaler, and that is an expander. It helps to ensure you get the full amount of medication and the full effect of the medication. It's called a spacer. So she delivers the dose of medication into the spacer, and then you'll see the mask is sealed over the child's face. And so as he breathes in, he's drawing all of the air and medication out of that spacer, so he's getting the full benefit of it. Okay, so theophylline is often is prescribed. It's more of a late line medication. If somebody is started on theophylline, they will monitor blood levels. You have to monitor serum levels. So asthma interventions, how do you keep it under control? Well, unless you have exercise-induced asthma, exercise is promoted. It helps to keep those lungs exercised. It helps to keep them open. It helps to mobilize secretions, as do breathing exercises. It keeps that tissue healthy. Try to avoid irritants or things that are going to trigger exacerbations. So whereas the problem is hypersensitization of the tissues, by avoiding all irritants, you're hyposensitizing them. And prognosis is unique to the individual, but if they are very compliant with medication and compliant with exercise and avoiding irritants, the prognosis is typically very good. So what is status asthmaticus? This is considered a medical emergency. And if it is not treated and reversed, respiratory failure and death can occur. So it's a continuation of the respiratory distress despite vigorous therapeutic measures. So maybe Lulu has started having symptoms of an asthma exacerbation at home when she returns from school for the day. and Grandma has administered her her 2 puffs of her albuterol inhaler, and 15 minutes later it hasn't helped, so Grandma administers 2 more, and half hour later it still hasn't really helped. So then Grandma, being out of her aerosol medication, she calls the ambulance, the medics, to come help. So they arrive, they place her on oxygen and a mask, and they give her some nebulized albuterol, and she's not experiencing relief from that. So at this point, her O2 saturation is like 84%. Her respiratory rate is at 50, and so they give her a shot of epinephrine, which is a vasodilator. It's a bronchodilator, and it opens up the airways. It helps minimally, and within 15 more minutes, that improvement has disappeared, but they've arrived by the hospital. So at this point, they've considered her status asthmaticus, and they do more epinephrine, more inhalers, they put her on a drip, and it takes 24 hours to get her to a point where it's not considered a status. I've already said the goals of asthma management. So this is a kid using a home nebulizer. Some of you have seen them in nursing homes as well. It can be administered using a mask, or it can be administered using a mouthpiece. Okay, so that's all I'm going to say on asthma. I'm stopping, and I'll come back and talk about respiratory conditions.